sclerosis. Yeah.
My felony.
That's scoliosis, not sclerosis.
That's just.
Sclerosis is like hard.
Multiple sclerosis, alright, so with multiple sclerosis, we have to think about the myelin sheaths and the nerve fibers that kind of run throughout your body within the brain and spinal cord. So that's what that big definition says. So it's an immune response that attacks the myelin sheaths itself. Do we all remember what the myelin sheaths do? Natalie, what do they transmit?
Oh, I thought you said what they were. They're in the nerves and they transport information.
Yep.
Kind of like the protective coating around a wire.
Good. All right. So what else?
They carry genetic information.
Not quite.
Don't they speed up?
They carry that electrical current or that electrical response. So when you're trying to move your hand to write down information, and your brain sends that electrical impulse to tell your hand to move, that's what this myelin sheath is going to do for your body. Okay, so it's kind of like an insulator, protector, allows for that electric current to go throughout your nerve endings and nerve fibers. Okay, so with multiple sclerosis, it's the degeneration or the breakdown of that myelin sheath, that insulator protective coating around those nerve fibers. That's what we're talking about with multiple sclerosis. We talk about multiple sclerosis, we have 3 different types. Okay. We got relapsing, remitting, we have primary progressive, and secondary progressive. Okay. We have relapsing, remitting multiple sclerosis. We have symptoms that occur. Okay. They last for a couple weeks, and then they return back to baseline, whatever they previously were, whatever their major baseline was, their movement ability was, that's what they return to. All right, and then a couple weeks later, a couple months later, they'll have some of these symptoms again, that muscle weakness and fatigue that we're going to talk about in a second. And so that's with relapsing, remitting multiple sclerosis. Primary progressive, they never return back to baseline. Okay, the symptoms present, and they progressively get worse. So that makes sense. Primary progressive progressively gets worse. Their symptoms progressively get worse. The secondary progressive, 9 times out of 10, they're going to start with relapsing, remitting multiple sclerosis, and then it's going to transition into your secondary progressive. So the symptoms are going to appear, they're going to last for a couple weeks, they go back to baseline, a couple months go down the road, they're going to get their symptoms again, and then their relapse period where they're not having any symptoms gets shorter and shorter and shorter. Okay, and then it becomes more of that primary progressive route. So where they're never returning back to baseline and they're always having those symptoms. Does that make sense?
So it relapses, then has mini spurts, and then turns to primary.
Yep. Okay. Questions about that? So with multiple sclerosis, you get fatigue, you get some cognitive changes as well. Scotomas, anybody know what that is? So over the eyes. Bella, what you got?
Small visual field.
What's people say? What's people say?
No, small visual field deficits.
Okay. So more of a centralized blind spot. Like Bella just said. Okay, so don't get hurt.
I know the next one more than that one.
What's the next one?
Involuntary idle.
Okay, nystagmus. Good. Involuntary idling. I think I have a video of that, so it'll make more sense in a minute. Okay. Usually you see this with some type of deficits. You'll also see it with strokes as well. But with nystagmus, you're getting them to follow your finger like we did in our basic assessment skills way back when. Remember that? When they look to the left or to the right, you start to see them kind of shake or vibrate their eyes almost, and it's an involuntary response. So it shows some kind of neurodeficit with that as well. Intention tremors and gait changes as well. This is something you can see. So here's this nystagmus. Everybody see that? Don't have to worry about audio. So just checking the visual acuity, look at his eyes, see how it's kind of shaking or moving back and forth as he's looking off to one side. Everybody see that? It's very subtle. Should show it again. See that right eye right there? Has kind of a shake to it. It's that involuntary muscle movement, eye movement that occurs.
Does
That
it
shows
progress
something.
as the disease progresses? Then it's gonna get worse.
It will be worse. If they develop nystagmus. Not everybody's gonna have nystagmus, but that's just a few of them, something that you're gonna see.
What if we like similar to the switch one?
Similar.
Does it just indicate brain?
Right.
Because
Sometimes,
my dog had a stroke and she died,
exactly, so.
and that's how they diagnosed her, and she got better.
Any kind of neuro deficit is not specific to necessarily multiple sclerosis, but some type of neuro deficit that nystagmus is going to occur. If we can fix whatever is the problem, then they can actually, alcohol, drugs, there's a lot of different things that can cause nystagmus.
So what many signs and symptoms contribute to the blind spot, the eye twitching?
Blood spots, the nystagmus, the paresthesia as well. I would also include gait changes and attention tremors. Really with all of these neurodegenerative disorders, it's gonna be muscle weakness, fatigue, gait changes. A little bit of cognitive change as well. And so really you can group the disorders together. You said, was it Montel Williams? You said that.
I did
You remember Montel Williams?
talk to her.
The top shirt off? Yeah.
More, no.
He's got multiple sclerosis. And then, the guy from Back to the Future, you know, Michael J. Fox.
Michael J. Fox.
You know who that is? He's
Yeah.
got it as well. So if you've ever seen any interviews with him, he's a little spastic. He's not the more rigid type. He has the constant tremor of his head, the more spastic movements with his hands, with his legs as well. So if you wanna see that disease in its true form, look up, Michael J. Fox, just any kind of interview at all, and it will show you. Diagnosis is really hard to confirm. There's not any true tests. Like for instance, you test for the flu and it pops positive they have the flu. Okay. There's no like nasal swab or no like blood test or blood draw that we can say yes they have multiple sclerosis. Right? So these aren't definitive. With your CSF, your cerebral spinal fluid, you maybe test that. So there's an increase cerebral spinal fluid. There's an increase in white blood cells. And an increase of your immunoglobulin proteins as well. Again, that's not a definitive diagnosis. It's more going to be based off the symptom presentation. When you're taking your physical history, your social history, that's going to be when you're going to kind of determine maybe it's multiple sclerosis. So they can also do an MRI of the brain and the spinal cord, and we can look at that. So does everybody see these little white spots? The white areas. It's called plaques, little hard massive areas. Normal brain is gonna look like this, kind of this nice gray matter right here. And then you have these plaques, so these little buildups right here, these little white areas. And that's gonna be one of your definitive diagnoses for multiple sclerosis right there. Okay.
What are the facts, different types?
No, they're all, you know. How are we gonna treat multiple sclerosis? Medications. We're really gonna hopefully treat the symptoms, hopefully delay the progression of multiple sclerosis. There's no cure currently. So we're gonna try to delay the symptoms. We have immunodilators. When you think immunodilators, think that it's very specific on the way that it attacks the immune system, the way it preserves the immune system, and modifies the immune system. Very specific on which exact cells that it occurs on. So that's really good when we put these patients on immunomodulators because we're not lowering their immune system. We're not making them immunocompromised like some of the other drugs we're going to talk about. Okay? So their infection risk is a little bit less than some of the other medications that we're going to talk about in a little while. Greatest risk for suicide and depression, seizures, we're going to talk about those in a minute as well. Definitely don't want to use alcohol with immunodilators. With the immunodilators, it's going to slow that progression, but hopefully not allow the immune system to attack those myelin sheaths as much, so delaying that progression and overall just destruction of the myelin sheaths and causing more symptoms. Okay. Immunosuppressants. So what's the difference with immunodilators versus immunosuppressants? Immunosuppressants, generalized, okay? So I put that in parentheses, you might want to highlight that as well. It's very generalized on the way that it attacks the immune system, where it modifies the immune system. It's not specific on the receptor sites, the cells that it interacts with. Okay? It just inhibits the DNA synthesis altogether, so it just blocks the immune system altogether. So the greatest risk is going to be that infection risk. It's really going to make our patients immunocompromised at this point. So that's why we like the immunomodulators a little bit better than the immunosuppressants. So generalized, greatest risk for infection. Kind of important. All right, then we have a monoclonal antibody as well. They all end in Zumab, Z-U-M-A-B. So that's kind of one way to differentiate those. I don't have a clever saying for that. I'm sorry. Sam, what's the process?
Very funny.
Oh, maybe that one.
I have got them on some time legislation.
Oh, okay.
But for the regular, we don't have that.
It binds to the white blood cells and just to prevent further damage of that myelin sheath.
I mean, we can put it.
Montezuma.
Montezuma. That's what is that?
Mexico,
It's a mountain.
the disease.
I mean, Dr. Oliver, then there's a second question because of Natalie. I mean, hello. My name.
Temple. A temple, that's right.
Natalie is in one.
Again, infection risk. So with all three of these medication classes or groups, they attack the immune system in some way, modify the immune system in some way. So the biggest thing is going to be that infection risk. What do we need to teach our patients then about infection risk?
Stay away from people who get it.
Get vaccinations.
Wear vaccinations, wear masks, good. Stay away from sick people. Frequently wash their hands, make sure they're clean and tidy. Large crowds, good. So they don't need to go in a room full of COVID people, right?
No,
So, I mean,
that's bad idea.
no hospital unless they can avoid it. And they're gonna have frequent doctor's appointments, follow-up care. So maybe wear a mask, wash your hands frequently, use all the alcohol pumps, maybe take a bath afterward, change your clothes when you get to the house, all those kind of things that we do after clinical every day, things like that. Just to try to prevent that increased risk for infection. With multiple sclerosis, we're not trying to cure the disease. We're only trying to slow the progression down of multiple sclerosis and then improve their quality of life. We try to keep them at baseline or help them maintain a certain level where they're able to do their daily meals as independent as possible. We need physical therapy, we need occupational therapy again to help them. That maybe they can get them on a routine, maybe they can modify certain tasks, able to put their shoes on a different way, maybe brush their teeth a those visual adjustments if we need to. So if we need to get it in with a eye doctor, we can, they're gonna give them some glasses. And then maintain our mental status as much as possible. Maybe some cognitive therapy if we need to. Any question about multiple sclerosis? Very short, sweet to the point. Gonna be the same way for a lot of people. Moving on to Parkinson's disease. Again, this is a progressive neurodegenerative disease. Right? With Parkinson's, you need to think dopamine. There's something wrong with our dopamine levels. There's some kind of decreased production. So we don't have that adequate level of dopamine. What does dopamine do for our body?
It makes you happy, doesn't it?
It does make you happy, that's part of it. Okay, what else? I don't know about breast milk.
Does it help cortisol levels?
Neurotransmitter, it will also help with muscle movement as well. It helps control our mental status as well, so our happiness side of things as well.
I think that's right.
It also has
Postpartum depression, that's easy to take.
and then also has a little bit to do with your fight response. Right? So it can help you increase your heart rate, increase your respiratory rate, maybe produce a little bit of extra sweat to help you with that sympathetic nervous system. Get you hyped up, get you energized, so that you can fire the wrong how you need to. With Parkinson's, there's 5 distinct stages. With Parkinson's, really you're not gonna see a whole lot of change in stage 1, that initial stage. Might see a little bit of weakness, maybe a little bit of hand tremor. They may just cough that up to old age, or I just always had that tremor. They don't really think of anything of it. They're probably not gonna come to you and say, I had some hand tremors, something like that. And then it's also usually just unilateral, so it affects one side or the other. You're really not gonna see them come in and say something that they're having some type of symptoms, they don't know what's going on, so they get to that stage 2 or stage 3. The stage 2, they have more of a mask-like appearance, so if you think of any of those Halloween masks, or just like a haiku mask, where it's just straight face, they have no emotion whatsoever, so not really even smiling. They really don't have any eye squinting or anything, it's just kind of a board-like, straight face, no emotional state whatsoever. Okay? If you think about it that way. And I got a picture of it here in a couple slides as well, what mask-like appearance is. This is when we start to notice gait changes as well. Their gait is gonna progressively get worse. They're gonna start to shuffle more, they're not gonna swing their arms like we normally do, they're gonna kind of keep them by their side at all times, and they're gonna kind of shuffle. Then their posture starts to change as well. They'll start to kind of hump over and kind of balance, and then eventually they're not able to do specific tasks while they're walking as well. They're not even able to carry like a drink or something, or carry their food to the table, or if something distracts them and you're talking to them as you're trying to immobilize them, they'll freeze up, they'll lock up, and they don't even know how to take another step. Okay, and that's usually when we get into stage 4 and then stage 5. That's when we're gonna start to notice those. So they're real severe disease, and then at that point they're completely dependent on others for their ADLs. Okay. So see how this guy has no emotion whatsoever? He's just kind of straight faced looking at you. That's what we're talking about with that mask-like appearance. This is also in your book as well, so you'll see that. Eventually, once we get to that final stage, they can also have some speech changes as well. They'll start to mumble their words, they'll start to combine their words together, so it just sounds like one run-on sentence. Speak real fast, yes?
I think this is the one, but is this the one where they don't want to go talking to you?
Eventually, they may kind of lose their ability to speak as well. Again, it really shortens their tone, their speech. Kind of jumbled up.
I don't know if it's the one I'm
or is this just happened?
It, just kind of happens. There is a genetic component to it, but it's not like you can just pass it on.
So like if my dad were to have it, that doesn't mean I could possibly.
Not necessarily.
When's the average age of onset?
Great question. I
Oh,
think it varies. Yeah, it will be able to.
Average age was 60.
Yep.
60.
So let's look at their gait. This video is going to show you the progression of their gait changes. So unilateral movement, she's not moving that right arm as well. Here again, that left arm, see how it's not swinging like it is. He's starting to shuffle his gait a little bit, not taking those wide, nice steps. Now we're continuously slowing down, really not moving our arms at all. Now we're getting more than moderate to severe. See how he's real stiff, kind of shuffling with it. Not real fluid motion with his steps. You can kind of see how postural will change as well. Now he has that more stooped posture. Now he's kind of hunched over. Definitely not moving our arms anymore. More that shuffling gait. In a minute we'll see the where they kind of pause, where they lag. We call it a freezing gait. There you go. Here's that freezing gait. So he gets to a certain point, he's carrying a tray. Now he's just kind of stepping, shuffling. He can't tell himself to take another step. Okay. Just give them a minute. Hopefully they'll kind of get out of this frozen state, maybe take the tray with them, and then he'll be able to initiate that step again. And it doesn't necessarily them doing like a dual task, carrying something. They said it can be because we're talking to the patient. We are overstimulated. There's a lot of noise, sound, movement, something going around in the nurse's station causing that to occur. Here's another where he kind of freezes up. He has that inability to take that next step, kind of tapping his feet, trying to shuffle to get to that next step.
So mentally, are they still there or?
Later stages, you'll see some mental decline as well. So listen to his speech on this. Little country music.
Welcome back to Using Speech Therapy. This is Sierra. Today I wanted to show everyone a treatment for
If you can think and not with such your aim, if you can meet with triumph and disaster, and treat those two imposters just the same. If you can bear to hear the truth be spoken, twisted by knaves to take a trap for fools, if you can meet with triumph and disaster, and treat those two imposters just the same. If you can bear to hear the truth be spoken, twisted by knaves to make a trap for fools, or watch the things you give your lives are broken, and stoop and build them up with worn out tools. If you can fill that unforgiving minute with 60 seconds worth of distance run, yours is yours and everything that's in it, and which is more, will be this man, my son.
So that's a therapy technique that they use as well, to help kind of break up those word sentences and see how we still kind of jumbled at that point. Well, yes.
Don't those with Parkinson's also typically suffer from restless leg syndrome? We do.
That's one of the components, the spasticity, part with the rigidity as well. The dopamine levels, it helps control, one way or the other, your movements. Diagnosis wise, there's no just test that says, hey, you've got Parkinson's. Okay. With Parkinson's, it's all about physical symptoms. They'll come in and start complaining of certain weakness, my gait has changed, maybe the family member has noticed them starting to jumble their words up, they're not able to perform their ADLs appropriately. Then we're going to start investigating what's going on. They're really going to eliminate everything else before they go to a Parkinson's diagnosis. So things like stroke, if they've had a stroke in the past, maybe they have multiple sclerosis, some type of neurodeficit. Why are they having the symptoms? Once they have canceled all that stuff out, then they can give a firm diagnosis of Parkinson's disease. Okay. Let's talk about how we can hopefully delay the progression of Parkinson's disease. And it's all going to be about medication management. So we have dopamine agonist here. I'm sure everybody has heard of levodopa-carbidopa. That's going to be within this class. This is going to mimic that dopamine within the dopamine receptor sites. So it's acting like dopamine, allowing to control or better controlling of that movement aspect. Don't want to give this with antidepressants. We can cause a hypertensive crisis. You remember what that was? Blood pressure over what? 120. Over 80.
I have a dyslexic moment, I said 120 over 180.
180 over 120. I like it. Levodopa-carbidopa. It's together. Levodopa-carbidopa, the bottom.
Is that what they both want?
You can also give apomorphine as well, which is a derivative of morphine itself, but the one you're going to see most of the time is going to be the levodopa-carbidopa. It's all one word. There's like a little hyphen there. When you pull it out, it'll say levodopa-carbidopa. With levodopa-carbidopa or your dopamine agonist in general, really it's in the beginning stages of treatment that it's most effective at slowing the progression, kind of the symptomatic management of it as well. They're really only going to prescribe for the first 3-ish to 5-ish years. After that, it's very non-effective. We don't really want our patients to be on these dopamine agonists for long periods of times because then it can cause the opposite effect and cause more rigidity or more progression, quicker progression of their symptoms. So they're not able to move as effectively. They have that rigidity about them. And we also have to educate our patients about the on-off phenomenon as well. And with on-off phenomenon, it's the symptoms present themselves, and then all of a sudden they're not there anymore. And then they present themselves again, and then they're not there again. And it really has to do with the dopamine levels, with the levels of this medication as well. And so when it's at its highest peak, that's when they're not going to have their symptoms. And then when we have that low or that trough level before the next dose is when they're going to have that on where they're having those symptoms. Anybody want to say this real class?
Had a call of
co-methyltransferase inhibitors. COMI, that's for short. Someone gave this the other day, I can't remember who came up to me with the entacapone. Anybody remember that? Who was in my clinical group? It was you, yes. That's what this is, so. So, this one's going to inhibit the metabolism of dopamine itself. So just allowing for a longer effect of that dopamine. We're gonna give this in conjunction with our, still not gonna work. Okay. We're gonna give this in conjunction with our dopamine agonist, okay? So you're gonna see your dopamine agonist with your COMIs. You're gonna see those together. They work together as a team. Never, ever, ever going to just completely cold turkey cut the dopamine agonist and the COMI drug classes together. Now I'm just going to cut them off. We want to do a slow taper. If we're going to taper them off, get them off of this drug and try something else. If we do that, then we're going to have a severe relapse of our symptoms and a severe progression of our symptoms with Parkinson's. Then we have our monoamine oxidase type B inhibitors. So your MAOI type B. Your MAOIs are also your antidepressants. So this is a subclass as well. And it's going to hopefully increase the production, that concentration of our dopamine itself, allowing for us to control those motor movements as well. If I was a student, I wouldn't worry about this last one. Yes.
Can hallucinations be a side effect of Parkinson's? Is that more of a medication thing or a side effect?
It's a combination of both. So Parkinson's, real severe, combined with some of your drug classes here, can cause that hallucinatory effect.
My grandmother has it. Can I bring her to class? No, I'm just kidding.
If you want to bring your grandmother to class, we'll have to show it to all.
I would not subject myself to that.
All right. So if they're having progressive muscle weakness, rigidity, their gait is affected, they are not able to perform their ADLs appropriately, what do we need to educate our patients on?
Fall risk.
Fall risk. How?
So they need to not have
Educate me
drugs.
on fall risk.
They need to not have drugs in their house that are gonna move with them.
Okay.
And they need to be careful with like how their house is set up, like cords across the floor.
I like it.
They need to have their bathroom probably close to their bed, things like that.
Good.
In the video, like, almost right now, ankle, or just one ankle.
Do they have ankle weights?
I think it was like weights, but it just was on ankle.
They might have some ankle weights, I'm not sure. What else for fall risk? Anything else that Natalie just said?
The little grip socks that they can wear around the house, or they
That's
can
supporting.
Yeah, canes, walkers are good. Socks, old people love to steal those socks from the hospital and they wear them all the time out in public.
Yep.
I don't know why. My granddad loves those things. He'll sport those old non-grip
Those are
socks.
the ugliest socks I've ever
They're
seen.
ugly, but he loves them. He thinks they're in style. So he's got his Skechers on and his skate socks. So that's what he likes. So can't fault him for that. What about their mental health? Is that important?
Yes.
Alright. So they're able to perform the ADLs independently, and all of a sudden they have this progressive disorder where they're having to rely on people more and more often. Right? So that's gonna cause some depression, I would think, right? If you can't brush your teeth or feed yourself, and then you're having to ask somebody to feed you or brush your teeth, that's gonna play out, okay? So maybe we need to have a mental health consult. Let's also not rush them with their ADLs. Let's allow them the much time that they need. And that can be frustrating as a nurse, because you're on the med surg floor, you have 8, 9 patients, and you're sitting here talking to this person with Parkinson's disease, and it takes them 30 minutes to take their medicines. Do you have 30 minutes to get your medicines?
No.
Maybe, maybe not. So we need to plan our care around that. So we know that whatever has Parkinson's disease, they're gonna take a little bit longer to perform their ADLs, to take their medications. I need to set time aside to make sure that I'm patient, willing, and able to provide care to this patient. We can also delegate as well, so, you know, we have the techs, we have the nursing students, things like that that we can delegate care to. And then we're also gonna talk about dietary, as well. Eventually, progression of the disease can cause some dysphagia. And so they get tired real easily, it affects their swallowing ability as well. So we need to maybe have some high caloric snacks, maybe frequent meals in between, not one large big meal 3 times a day like most old people love. They love breakfast, lunch, and dinner, and that's all they ever eat. Why they don't default small frequent meals, it's just the way they were raised. I've seen a lot of patients in the hospital too that love those little boost drinks. A lot of calories in there, a lot of protein in there. So if they want boost on the rocks, give them boost on the rocks, right? That's small frequent meals that we can encourage to get a lot of calories into our patient. Boost is actually really good, so.
Premier's better.
Premier is better. Hospital's not fancy, they don't have those Premier shakes.
And then Fairlife is even better.
For your patient education, I would look at box 36.7 on page 896 of your med-surg textbook. It gives you a full list. This one's a pretty full list, but it has some specifics and stuff. Box 36.7, page 896. Anybody ever seen a seizure before?
This is Sarah, registered nurse, RN.com, and in this video, I'm going to be going over
sorry,
seizures.
well,
And this video is
shut
part of the
up.
complex review series over the nerve.
Okay, get your mouse. I did, it wasn't working.
Did you eat Waffle House and watching Mr. Sarah?
No, I clicked on the link.
Has anybody ever seen a seizure before?
Yep, be careful.
Terrifying. When, how they present? What did you see?
Depends on, what level of seizure you want to see.
What did you see?
I mean, you can see everything from facial focal seizures all the way to grand mal seizures.
Yeah, all fancy terms. Just basics.
They can
I had
just
a
stare
friend-
off into space.
Stare off into space, good.
Yeah, my friend would have like roller, like eyes, like, she had many seizures.
Convulsion.
Did she have?
Have you seen the really violent ones where they shake all over the place?
Yep. Mhm.
Those are pretty scary.
We have to call the ambulance each time, he does not stop, even with the guys, he does not stop. He's
Yeah.
got to go to Adam Man a couple times in the hospital.
Some patients, they get real rigid. We had a guy, I won't say his name, but he was pretty famous in East Alabama because he was a frequent flyer. So he came to the hospital for the same thing multiple times, but he would lock up, get rigid, and then at the last second, his arm would always cross over like this and become rigid. So if you weren't careful and you were at bedside, you'd get punched in the face. So all of them present a little bit differently, and the way they present is gonna be how you're gonna classify these seizures. So seizures can be any kind of excessive movement, rigidity, loss of consciousness. There's something wrong with the neurotransmitter part of the brain, something that's affecting the way these electrical impulses flow throughout the brain. Okay, that's what we're gonna classify seizures with. It can be any kind of abnormal electrical neuronal activity or an amount of the neurotransmitters gamma aminobutyric acid, or both of those. So gamma or GABA, so GABA, you'll see it as well. Gamma aminobutyric acid, one of the big neurotransmitters within the brain. When we talk about seizures, we have 2 different classes, and then we can further break down those classes when we talk about them. We have generalized seizures, and then we also have partial seizures as well. When we talk about generalized seizures, we break it down into 5 different categories of generalized seizures. I'm going to go to the next slide. These are all the definitions for your seizures. But this slide makes it a little bit easier for you to understand. So we have tonic seizures. So we have that tonic phase, or the tonic seizures. We can have just the independent tonic seizure itself, and that's what we're going to classify as that rigid motion, where they lock up their muscles, they get real stiff, they get real tight, they have a real rigid appearance. So he's even bowing his back a little bit, he has his arms fully locked out, real tight, leg muscles are rigid as well. That's what we're gonna classify our tonic seizures as. And then we have clonic seizures as well. Clonic is gonna be more of that rapid shakiness, rapid movement, jerking, rhythmic jerking movement that you typically think about when you think about seizures. Nobody really thinks about the real rigid part, they think only about the rhythmic jerking section. So that's gonna be your clonic seizures or your clonic phase. We can also have a clonic seizure as well, where they present with both of them. So they'll go through the tonic cycle first, they'll have that more rigid moment, and then they'll progress into the clonic phase where they start to have that rhythmic jerking phase. Usually it's gonna last around 2 to 3 minutes, give or take. And then the other two types of generalized seizures that we're gonna have are the myoclonic and the atonic. With myoclonic, that's also gonna be more of that rhythmic jerking. It's gonna be more of a subtle appearance compared to the clonic seizure type. With your myoclonic, it's just real small movements and they don't last as long, maybe 2 to 3 seconds at max. With your atonic seizures, this is when they'll lose their loss of consciousness. That's where they're going to kind of pass out. They kind of blank out for a little bit and come back to. So that's those 5 different types of generalized seizures right there. Questions about that? That makes sense for everybody? So they can be independent of each other. They can have just tonic, or they can have both. They can have tonic, clonic seizures. Normally you don't see myoclonic and atonic together. It's always a tonic, clonic seizure or one of the other 4. So let's look at a tonic clonic seizure. So he's going to begin by his tonic phase where he kind of locks up. He's even starting to lock up now. Arms starting to get rigid. See how he's getting very clonic. He lays over to the side here, and then he's going to start his clonic phase. Go on. See how he's starting to shake, have that rhythmic jerk pattern. That's going to be the clonic phase. So 6 minutes, but not a lot, 6 minutes. Does that make sense? Do we need to replay that again? No? Okay. Tonic phase, that rigid moment. You saw him kind of lock out his arms and kind of roll off to the side. And then he had the clonic phase where he had that more rhythmic jerk. This one's a very quick video. This is your myoclonic seizures, so the just kind of fast, real subtle jerkiness. It's only going to last for a couple seconds. So really look at it in their arms, her hand right here that she's holding her drink with. And then she's back to normal. Okay. So it only lasted 3-4 seconds, and she was right back to normal.
Unless they put them on oxygen, so I guess it affects their breathing.
Yeah, we'll talk about it. This one had body difference. Can't decide if this one's real or if this was just a skit. I think it's more a skit. We'll watch the whole video of this. And this is going to be your atonic type seizure.
I don't believe it.
What's wrong now?
My mum's forgot I've got football tonight.
And?
Nothing. It doesn't matter.
So you say, oh, I don't believe it, and nothing.
Don't be so nosy.
You're due to join in. Mum's forgot my kit again.
Come on lads, get a move on.
So I've got no kit. It's alright.
Maybe something in the cupboard you can use.
You can wear those red shorts again then.
Andy?
Andy? Andy? Andy, you okay? Yeah?
So is he gonna be okay?
Yeah, he's fine. You two go and join Miss Macon in the gym, okay? Me and Andy are just gonna sit here for 5 minutes. You okay? Yeah? You'll be fine.
I like her British accent.
Okay.
Looked very stiff, but that was a skip.
Probably.
Looked very like a skip.
Did everybody see where he kind of lost consciousness, fell? He did kind of multiple times, he was kind of out of it, didn't really understand or realize what was going on around him, and that's what we're gonna see with that. The other class that we're gonna talk about is the partial seizures, and when we talk about partial seizures, it's going to be broken down into 2 different categories. We have complex partial, and then we have simple partial seizures. With complex partial seizures, we're gonna have kind of blackout time, if you will. They're not necessarily gonna pass out all the way where they fall out on the floor. They're just kind of not really aware of their surroundings. They don't really remember anything. They kind of just have this state of just offness. Sometimes they will black out all the way altogether, where they pass out, they lose consciousness fully, and then they'll wake back up in a couple minutes, and again, not remember anything. And then they'll also have some where they don't lose consciousness altogether, but they're still unaware of their surroundings. With simple partial, they never lose consciousness throughout. And then there's kind of a blank stare, they're kind of absent. Usually they're going to know these before they occur, when they're going to occur. So they're gonna report these auras. Okay. Anybody know what an aura is?
Shadow, the halo.
Halos, good, what else? It could be a lot of different things.
Yeah.
A lot of people will report halos, maybe smelling a strange smell, maybe a slight headache before. Some have also reported maybe a deja vu effect, where they've kind of been there before and then they go into this kind of absent state. There could be a whole list of things with your auras that they report. Watch the guy that's speaking right here.
You're okay, Adam. You're fine, you're okay.
So he's kind of unaware of his surroundings, has this kind of blank stare. If you notice his, I think it's his left hand has kind of this repetitive movement with it. He kind of goes up and down with his jacket, playing kind of with his jacket, his collar right there. We'll see that as well. And she's talking to him, but he's still unaware of what's going on.
You're okay, you need help?
Also watch kind of what she's doing. This is what we're gonna do. If somebody has an active seizure itself, see how she's kind of guiding them.
Okay, do you mind pushing back the chair, please?
She's taking chairs and other dangerous objects out of the way. So if there's a trash can, or if there's cords or rugs, anything that they may run into and hurt themselves, we're gonna take those out of the way, kind of guide them. We're not trying to wake them up, trying to get them out of the seizure necessarily. We just need to let it pass.
Fine.
And then they'll kind of just come back to you. That makes sense.
So would they be to go see the doctor?
Usually they can proceed with their day if it continues to happen frequently. If they kind of develop some type of injury, so they ran into something or they fell, then it's gonna be more of them going to the hospital for other reasons, not necessarily for their seizures. But if it continues to happen and it gets progressively longer, then that's something we need to take them to the hospital for. So we have our high-end points. They're all gonna end in point. TOIN. phentoin and your phosphentoin. Your phentoin, the name for that is gonna be dilantin. I don't know if anybody's heard of dilantin. This drug class is more the big boy, the serious ones, the ones that we're gonna give when other options don't work. This is usually what we're gonna give. For the treatment of seizures, with these medication drug classes, we're trying to suppress the central nervous system. So what do we have to worry about when we're suppressing the nervous system?
Like bradycardia,
Bradycardia, you just pointed out, so everything decreases, right? So low heart rates, low respiratory rates, grogginess, drowsiness, maybe decreased LOC. So you said low heart rate, so that's good, sinus bradycardia. We can even stop their heart if we give it and they are too sedated, almost have that sedative effect. We can actually have a cardiac arrest. And then we have a whole other issue besides just a seizure. No alcohol with these. You pretty much count alcohol out for most drugs, but I'm just throwing that out there as well. So we have aminostilbenes as well. Your typical examples, your carbazepine and your oxycarbazepine. I think you get this one as well. Yes.
Yeah.
We're really affecting that overall response of the CNS and that's ability to transmit information or transmit that electrical current or electrical impulse that's allowing for these changes to occur. So we're trying to decrease that rate. I wouldn't worry too much about this slide. We also have your succinimides as well. We're overall just affecting the level it takes, the amount of excitability it takes, the amount of electrical current that it takes to cause a seizure. That's what this drug class is representing. I wouldn't worry about too much about this one. This one's kind of important. Benzodiazepines. The go-tos. What's an example of that? Lorazepam, good. It's also on the bottom of the slide as well. So what's the other name for lorazepam? Ativan. That's a great drug. I love Ativan. Not me personally, I like to use it. So again, that GABA words popping back up. That's that big neurotransmitter that's allowing for these electric currents to occur. Overall, benzodiazepines decrease the work of the CNS, so your central nervous system in general. We have more of that sedative effect with these benzos. With all these drug classes, we're going to have that sedative effect, but benzos most often. Like I said, we already said lorazepam or Ativan.
Is diazepam in this class?
Yes.
Okay.
Benzos are usually reserved for seizures that are uncontrolled, emergent situations as well. Or usually that's when you're mostly going to see it within the hospital setting. They usually put it on the PRN list and say if the patient has a seizure, give this. Basically what it's going to say. We're really treating the management of status epilepticus. Anybody know what that is? Going up? Stay in a seizure. Good. So seizures lasting greater than 5 minutes, or rapid succession of seizures.
Like one right after.
So one right after the other. Maybe they have a slight break or have a post-ictal state in between their seizures, and they go right back into it. Or it's that long, drawn out 5-minute or greater seizure. Really need rapid onset with this, so more than likely you're going to give an IV. So So in the hospital setting, what do I need to worry about with seizures? What do I need to educate my patients on? What do I need to worry about most often?
Injury.
Injury, okay, injury. Why?
Because they have no control.
No control, they're violently shaking, they're sitting in the bed. Maybe they're walking around and they have one of these seizures, so they're at a really great fall risk. So how are we gonna protect them for this kind of stuff?
Head bumpers.
Good. And I have it, oh, this one, there you go. In a hospital setting, we have these fancy pads throughout. We can put them on side rails. We can also put pillows behind their heads. So when they go into a seizure, they have that tonic-clonic seizure where they're real rigid, they have uncontrolled movements, and they begin to have that rhythmic jerking. There's no telling what they're gonna do, right? So they may bang their head against the side rail, they may bang their feet or their arms against the side rail, so we need to protect them at all costs. What if I don't have these pads? Blankets, good. I know when I worked in ICU, we had one set of these pads and we could never find them, ever. Don't know why, we could never find the things, and then when we did find them, it was too late. So what do? You improvise, right? So you get a bunch of blankets, and then you just duct tape them or tape them around each of the side rails, and it creates that padding effect. You don't have blankets, grab some pillows. Do something to protect your patient from harm. Aspiration risk, who said that? Now they said that. Aspiration risk, that's another big one for our seizure patients. So what are we gonna do? When our patient has a seizure, this is within the hospital setting, or if you're out and about in the world and you're at Walmart and someone starts having a seizure, these are some things that we can do. To prevent that aspiration risk, we're going to lay them on their side, that lateral position. Right? Then we can also tilt their head back and out. So if they do end up vomiting, it doesn't go back down into their lungs, it can kind of go off into the side. That makes sense? With aspiration, we can also have suction equipment as well. So if we're in there and they're having an active seizure, once we lay them on their side lateral, there's still a chance or risk for aspiration. But we can also help that when we have that suction. So we can put that suction kind of around the outer edges and suck out any excess that we see. Right? Never want to stick anything within a patient's mouth when you're having a seizure. We have a potential risk to hurt their dentation, so they can break their teeth, they can clamp down. If they clamp down hard enough, are they going to break off whatever you put in their mouth, and then they can aspirate on that. So a lot of options with that. We're never going to restrain our patient either. So the tonic-clonic video, did you see where he laid on the side and applied oxygen? He kind of kept them in the middle of the bed, but he wasn't holding them down. He wasn't not allowing for those movements. It's okay, they're having a seizure, they're gonna move. Go ahead and let it happen. We're not trying to restrain them, to lock them down, hold them in place steady. That's not what we want to see. After a seizure, what do we want to do?
Experimentation status.
Segmentation status, I like it. What else?
Reassure them.
Reassure them, good.
Clean their bed because they've probably urinated and defecated on themselves.
Robin. What else?
Check their oxygen.
Good, vital signs, all right? Heart rates, respiratory rate, oxygen level. If they aspirate, is their oxygen level gonna be stellar? Probably not, all right? We also want to document how the seizure occurred. So I like to say how, what, when, and where of a seizure. Was it some type of medication that we gave? Are they going through alcohol withdrawal? Do they have some kind of allergic reaction? I had a guy, he said that when he ate food, he would have a seizure. I don't know if he was faking it or not. We give him food every time and then he would look like he had a seizure. So who knows? Never heard that before as an aura or something that would stimulate a seizure response. But it looked pretty real to me. I don't know. We give him Ativan and then he would get back out of it, and then for lunch he would eat and then he'd have another seizure. So You give him his food tray and then a syringe out of hand, and you would have it right there for them. So what precipitates it? Is there some type of aura or something that occurs? We can talk about that. When did it occur? How long did it occur? Is it always first thing in the morning? Is it right before bed? Did it last more than 5 minutes? Or was it a 10, 20-second seizure and then they were back? Did they have a postictal state? So what does postictal mean?
That means the confused state after the fact.
Yeah, does that kind of confused, groggy, not with it, really with it, not responsive state right after a seizure? This causes a lot of stress within the body, and so it's kind of like a reset button for our body, allowing that time to rest and reset. And then where? Did it occur in the floor? Was it in the bed? Were they on the toilet? Something like that. Was there any kind of injury resulting from where they were at when they had their seizure? And then if you want to further classify it and think about what type it was, you can also split that as well. All right. Box 36.10 on page 906. It's a great box to look at as well. I'm just going to talk all about your patient education as far as seizures are concerned. We really want to discuss with our patients medication management for them to be real compliant with their scheduled dosing. So if they're on medications, they need to take them. Just because they haven't had a seizure in a long time doesn't mean that they can just stop taking their medication. A lot of times for any disease process, oh, I don't have high blood pressure anymore, so I stopped taking my meds. Oh, I didn't have a seizure in 2 years, so I'm not taking my meds anymore. Well, the reason they're not having seizures is because they're on medications, right? Let's encourage them to stay real true to their medication regimen. We also want to encourage our patients to let us know if they start taking any new medications, or tell their physician that if they're taking any new medications. There's a lot of interactions with these seizure meds. We need to educate them on what to do during a seizure. So let's recap. What are we going to do first with a seizure? We go to Walmart and we see a patient start to have a seizure. Sit them down, okay. If they're already down on the ground, what are we going to do? Turn them on their side. Good. What else?
Move stuff out of the way.
Move stuff out of the way. All right. We're going to put anything in their mouth?
No.
No. Okay. Are we going to constrict their movements?
No.
Good. Are we just going to walk off after the fact?
No.
No. Stay with the patient. All right. Once they get back to, what are we going to tell them?
It's okay.
It's okay. We're going to reassure them. We're going to let them know they had a seizure. Is there somebody that we can call? There's wife or whoever with them. And then we need to call 911 at this point and let them know what's going on. And then, if they have some type of aura, let them know to let us know. That way they can get to a safe spot once they feel that coming on, because they know they're fixing to have a seizure. Or maybe it's some type of environmental factor that's causing these seizures. So the guy that was eating food and then had a seizure, he knew if he ate food, he would have a seizure. So when we gave him his meal tray, we were able to prepare for him to have a seizure. So we can kind of prepare the room, prepare the bed, how we needed to. If certain smells trigger it, so if they have a real strong perfume or something, if they go to church, they know they might smell a real strong perfume, so they need to be wary of potential for a seizure. Questions about seizures? Take a 10-minute break, and then we'll get started with nutrition.